I'm Catherine, and I'm the clinical trials manager at a research group based at King's College London. We're based in South London, and we focus on doing clinical trials with psychoactive substances, including various psychedelics. So I'm going to go into a bit more about what we do, but just to introduce myself, I come from an academic background. I did a master's in neuroscience, specifically cognitive neuroscience, around 2018, and then I started as a research assistant at King's. We were initially called the Psychedelic Trials Group because that was kind of the main substance or drug or medicine that was being researched at the time for different psychiatric indications. But now, as you all know, the landscape has changed a lot, and there's lots of different types of research going on. So yeah, I hope you find this talk interesting, that you learn something, and hopefully we have some time for questions at the end. I will try my best to not talk too much. So this is who we are. We are a multidisciplinary trials group. We're made up of psychiatrists, psychologists, psychotherapists, researchers who have a more academic background. We have PhD students. We have nurses. And we all sort of work together to bring different perspectives within the context of healthcare to the research that we do. We mainly work in collaboration with a NHS clinical trials research center. So for those of you, maybe you all probably know what the NHS is, but it's the UK's National Health Service. And we at King's College are a research university, so we sort of work in partnership with the NHS, and we're sort of interested in understanding how these treatments might be applicable within the National Health Service. And I think that's quite interesting and important because it's in contrast to the States. We have a mechanism where potentially psychedelic-assisted psychotherapy could be available, perhaps free of charge. So that's sort of our main focus. So I think it's important to always disclose who we work with. So we work with a bunch of different outfits. We have government funding from the National Institute for Health Research. We have independent sort of funding from the Wellcome Trust. We work with various companies and sort of life science and pharma companies who are sort of working to develop different substances alongside often psychotherapy or psychological support. So one of our PhD students, Emma, who's sitting there, works doing global drug survey work. So there's lots of different things. It's kind of like a patchwork of different funding, and I think it's just important to point out that this is who we work with. I will say it's also important to note that Alan Young and James Rucker, the two people on the side, their funding is sort of independent of the kind of private funding that we have, and even though we receive funding from these people, we report directly to them. So there's a sort of step there, but I just want to put it out there, and you can kind of make your judgment about the biases that might be involved in the work that we do. So this is the kind of vision of our research group. The vision is to undertake robust, high-quality clinical trials and related research with psychoactive drugs, often combined with psychotherapy or psychological support. And at the core of this vision are the participants who volunteer to be a part of the group's trials. The well-being and the safety of the participants is our first concern. The integrity and the quality of the trial data is the group's second concern. And the core ethical principles are the 4 pillars of medical ethics. I won't read the rest of it, but what I'm trying to say is that I think it's important to bring these things up because within the psychedelic research space, things seem to be moving at rocket speed, and everyone's very excited about the potential for these drugs, but it's very important to do things like report adverse events properly and make sure that the people in the trials are being treated with good care. And it's something that we try and do. Obviously, it's sort of a nebulous kind of field, and everyone's still learning about what best practice might look like. So I just kind of want to point out that we're not quite there yet, and it's sort of important to keep these things in mind and take things slowly and do things sort of properly. So what I'm going to be talking about today, I'm going to try and separate out the talk into 2 parts. I'm basically going to be talking about sort of the representation or the lack of representation within participant samples within the existing clinical trials research within the psychedelic space. I'm going to outline why it's important to have representative samples within research, explore why, even though we've been having these conversations for so long, why there are barriers still and what they are. And then using examples of some of the really practical steps that we've put in place at our research group to try and improve this lack of representation within our clinical trials. You can't see what it says there, but I want you to kind of think about in what context might categorization of identity be useful. So it's not always useful to sort of group people by different qualities that they may have, but in some instances it is useful, particularly when you're trying to keep on top of what is happening, and that's going to be what I'm talking about at the beginning. And then we're going to move on to part two, where it's a bit more of an open discussion, where we're going to talk about contexts where identity categories may be immobilizing and not helpful. Talk about the importance of moving beyond categories when they're no longer useful, introduce concepts of engaging with identities that are constantly in flux, also acknowledge that there are no essential attributes that are discrete or static across categories, and then reflect on this in the context of matching participants who enroll in the trials with therapy pairs within psychedelic clinical trials, and how that's not sort of so straightforward, and it's a bit more of an art and it's delicate. So what are some of the categories in which people may be grouped together? I've taken this from the National Institute for Health Research, so I'm not going to read all of them, but some of the demographic factors that you might know of how people get organized or sort of categorized by gender, ethnicity, sexual orientation or preference, their age. Some other factors include things like whether their residential circumstances, or how literate they are at digital platforms, what language barriers are there to them accessing research, what mental health conditions do they have comorbid mental health conditions. And I think it's important to pay attention to this when you are doing research. And with scientists, we are sort of objectively minded, and we try and operationalize these kinds of facets into data that can be used, but in a way to make sure that we're not excluding certain groups, rather than sort of defining people by these different categories. And I think this term, it says underserved groups. I read it somewhere, and I think I kind of prefer it to underrepresented groups, because kind of what I was talking about, the whole aim of trying to develop a treatment or a service in which we are, within the NHS, providing service to people who are using the service. It's interesting to think about who we are underserving rather than being underrepresented. So why is it important? And I apologize if you're sort of, kind of well-read in these areas. You may already know this, but I'm just going to say it for sort of completeness. Failing to include a broad range of participants means that results may not be generalizable to a broad population later down the line. Different groups may respond differently to an intervention or medicine or treatment due to differences in their physiology. And only by studying the effects of an intervention in a range of groups can we be sure to balance the risks and the benefits. So, when sometimes you treat someone who is in a particular state, sometimes there will be risks with the treatment, and you need to make sure that those risks are actually worth the benefit. Also, if clinicians lack evidence of the effect of an intervention within a particular group, they may be later reluctant to offer this intervention to that group later down the line, and then it sort of becomes this random clinical opinion and let's just see what happens kind of approach, which is not very good if you can kind of start to think about these things earlier on. And at the end of the day, the successful delivery of an intervention within a very complex system is there's sort of lots of logistical things to think about, and there's a lot of factors at play. So another reason why it might be important to think about different categories is how different people express different facets of, let's say, depression. And an example is somaticization. So there's differences among different groups and how cultural styles of expressing distress may not be uniform, and this is something that's been known for a long time. When I was reading the literature, there were lots of other examples, and I was actually thinking how probably they're not very up to date. And as generations of people who kind of move to different countries and move to the West and sort of access Western medical systems, there are levels of acculturation. So when first gen may react different to second gen. So I didn't really go too much about it, but it's, if you want to look it up, there's lots of research about it. So what are some of the barriers to people accessing research and sort of healthcare services in general? Mistrust, a lack of understanding of value, there's fear, there's stigma participating, and this is probably to do with a lot of history that's, there's a lot of atrocities that have been done within research in the past, and it's important to sort of validate and sort of accept that these things have happened. Lack of comfort with the clinical trials process, mistrust of the process, fear of the wider community's opinions, misinformation. There's also time and resource constraints associated with clinical trial participation. It's financial burden to take time out of your work to come and take part in a clinical trial. So, a lot of the time the people who apply for clinical trials are sort of middle-class people who have time to do these things. And lack of awareness about clinical trials, which is sort of just a repetition of what I've already said. And I think I'm still actually quite surprised we receive so many people who are interested in applying to our trials. And there's been quite a lot of scandals, over the past few years with different participants having very difficult and sort of traumatizing and sort of instances of abuse, yet people still do apply. But yeah, just thought it would be, it's interesting to think about the perception and the hype and how that contributes to sort of enthusiasm for psychedelic research. So this study was published in 2018, and it was a review of all the clinical trials that had been done to date. And basically what it found was that 82.3% of participants were non-white Hispanic. And you can read the statistics there. So within psychedelic research, the lack of representation is mirrored as it is with other clinical trials research. And it's been 5 years since this time, and maybe one day I'll do a review if I have time of the updated literature. But I'm going to use ethnicity as an example, but this sort of can apply to lots of different facets, other ones that I've already described. So MAPS released their phase 2 results, and this is they sort of working to bring MDMA-assisted therapy for people with PTSD, sort of similar lack of representation. And you might think, okay, it's not that surprising considering it's done in North America and Canada, where the majority of the population are white, but it is not representative of the population regardless. So, yeah. So, and at our group, we've had similar results. And these trials were done in sort of 2018, 2019, 2020. And as you can see, the demographic makeup of the ethnicity of our participants sort of mirrors what's been found. And so, I've kind of talked about the barriers and some of the reasons why this might be the case. So if you want to change these things, you have to really make an active effort. So these are some of the things that Monica Williams and her team identified as being helpful in a study that they did, which was focusing on treating race-based trauma with MDMA-assisted psychotherapy. And so we've tried to do some of these things, and I'm just going to use our group as an example of how some of them have worked, how some of them may have worked a little bit, and how the change has been slow, but it is there. Yeah. So this is who we were in 2019. Let's leave that for a second. this is who we are now. So a bit of change. And sometimes I think, what does representation even matter? If you look at like the Tory party, there's people of color there too. But when you are working, sorry, no offense if that's your political. So this is. I just want to show you this because this is like death by bureaucracy. This is the clinical trials process, and like we were all like small people like in and amongst this process. And if you are also trying to focus on improving representation, you will be, so you're drowning in a lot of things. So there is strength in numbers, and if there's people who you can collaborate with to bring an aim forward, it is important to have more than just a few people. So one of the things that we also did is we came up with representative targets. So we aim to meet a certain target within our clinical trials. And so what we did is we took the data from the census survey, which is that survey that you get mailed every 10 years, and you're like, I'm mixed, white, Asian, and blah, blah. And then you fill it out, and it gives you national demographics. So this is just an example. So the targets that we made are averages of the whole national number and then the London number, because London is more diverse, right? So we are doing studies that will be, if it becomes available on the NHS, it's sort of a national thing, but we also didn't want to sort of exclude the diversity that is present in London because we are also based in London. So these are, this example, I won't read through all of it, but that's the London percentage, that's the UK percentage, and then these are the targets that we've come up with. So so as you can see, the recruitment target for Caucasian people would be around 72%, where we were hitting things like 80 to 90, so quite far off. So this is one trial that we have ongoing. It is a trial looking at psilocybin for treating treatment-resistant depression. And I'm just going to show you some of the figures and how we're going so far in terms of recruitment. So again, if you just look on the side here, this is the target. So we're aiming to recruit 60 people. And then this is how we're doing so far. We've recruited 28 people. So we are doing a bit better. We still have more to do, but it's good that we are keeping track of it so that we can make sure that we're sort of aiming for those targets. I don't have time to read it all, I'm sorry, but if you want this, I can send it to you. So it's very important to think about why some trials are able to be more representative than others by the inclusion-exclusion criteria that they have. So on the left is the study that I was talking about, that we had sort of 92% Caucasian people. And this is CIDR, which is currently ongoing. So the definition of treatment-resistant depression in the inclusion criteria is very different, where this one is more inclusive. So instead of having to have had 2, 3, or 4 pharmacological treatments failed within the current episode, this one you can have had 2 or more antidepressants, or at least 1 antidepressant and evidence-based psychotherapy. So it's sort of engaging with people who may have tried antidepressants, not like them, have tried therapy, whereas this one is for people who have tried at least 2 antidepressants. And so, just thinking about how you design your clinical trials is important, thinking about who's going to be able to apply and who's going to be able to access the treatments. Just to explain a bit about this, why people do this, it does also kind of make sense because these people have been failed by the system already. So they've tried to engage with the system quite a lot and have still not gotten better. So trying to also think about how you can help those people is thinking behind these kinds of things, but it is causing a lot of people to be excluded as well. And we've sort of tried to think about these things in some of our other trials. So in one of our trials for post-traumatic stress disorder, we don't actually require diagnosis from an external healthcare provider, whereas for other trials, you need sort of a diagnosis from your GP. And this then increases accessibility because a lot of people with PTSD tend to access things like private EMDR, and that's not a recognized sort of diagnosis per se. And I'm sort of running out of time, so I won't go into too much detail about this. So When you also have a more diverse team, it means that there's a lot of different opinions that kind of are floating around with the group. We have supervision every 6 weeks with a systemic psychotherapist in which we can talk about these things. We have a lot of difficult conversations. Not everyone always agrees, but it's important to have a space where people can be heard, and so we can work collaboratively. Could I have 2 more minutes? Cool. So I'm just going to give a case study of how we can also work flexibly within this. So we had a participant who reacted sort of to the assigned assistant therapist that they were assigned with. They sort of said, I don't want to work with this person for varying reasons. And instead of sort of saying, well, you have to or you get out, we sort of found another member of the team who we thought they might work with better. And we sort of proceeded to the dosing session. By the flip side, there was one time when one of the assisting therapists had a very uncomfortable interaction with one of the participants in which they sort of said things that were not very appropriate. Then the way that we respond is by swapping them out. So it's sort of a protection of the team and also trying to engage dynamically with the participants' needs. Just going to skip through. So just to finish off, I just want to think about what context identity categories might actually be immobilizing. And I like to think about this concept of double bookkeeping, where you have the material, so the categories and the things that I've been talking about, things that are rooted within society, sort of being a part of a particular group and what that experience might be. It's not something you can put down. And then there's a sort of the more experiential part, which is the relational aspects of our identity, how we feel when we are responding to a specific person, what the interaction makes us kind of feel, how we update our models of other people and ourselves in relation to other people. And these are some of the things that we think about when we match people with therapists. So it's not just Famia, one of our psychiatrists, always jokes about ethno-matching. She's like, well, why have you matched me with this other person of colors? Because you think that we're just going to get each other. So, it's thinking about other parts of people's psyche, personality, socioeconomic status, and how we can work dynamically with what they bring to the table. I think I'm gonna maybe just skip through this and we can talk about it if you'd like to ask me about it. But just thinking about the concept of set and setting and how what I've been talking about fits into these 2 different concepts of the psychological set that people bring and the environment in which we are providing this treatment. I just like this. And I actually took part in a clinical trial with ketamine. I was a participant, and what really came to mind to me was the fact that agency. I was consenting to take part in the clinical trial, but my sense of agency really didn't feel like something that I had, but it was suddenly part of this relationship between myself and the team who I was a participant for. And it was probably a good experience for me to do that, someone working in research. Thank you.